Thank you very much. Thanks a lot to Biology Education for the invitation to give this talk. These are my conflicts of interest that are all unrelated to the content of this talk. And this is the content I will try to follow for this 15-minute presentation. So this is the current situation of the COVID-19 pandemic the day we're recording this presentation, with 4.5 million deaths already worldwide, but also with close to 5,000 million doses of vaccines already provided. And this is the current situation of the HIV pandemic. And as you can see, there is not a clear geographical overlap, maybe with the exception of South Africa that has been hit very hard by both pandemics. And this is fortunate because at the beginning, initial studies suggested that probably there will be no higher incidence or higher attack rate of COVID-19 in people living with HIV, or a more severe outcome of COVID-19 in people living with HIV. But however, more recent, bigger studies have suggested that people living with HIV may indeed have higher SARS coronavirus 2 attack rates and also poor outcome of COVID-19. So let's move to the first main topic of this presentation, which is the risk of COVID-19 in people living with HIV. And I think that these are the three main points I would like to discuss for this initial topic. One, does HIV infection itself increase the risk of COVID-19? The second is, can antiretroviral drugs provide protection against SARS coronavirus 2 infection? And then the third, in the context of this huge number of doses of vaccines that have been already provided worldwide, how is SARS coronavirus 2 vaccines performance in people living with HIV? So let's try to answer the first one. So initial studies suggested similar incidence compared to the general population of COVID-19, but these studies were quite variable with the results, or even contradictory, some suggesting higher, other equal, and other lower incidence compared to the general population. And across Europe, as you can see, the incidence of COVID-19 among people living with HIV ranges from 0.3 to 5.7 person years. However, a recent meta-analysis that you can see here, published very recently, have suggested that, in fact, people living with HIV were more susceptible to SARS coronavirus 2 infection with a risk ratio of 1.24. But if you take a look where this conclusion came from, this is the figure where you have all the individual studies giving this relative risk for the attack rate of SARS coronavirus 2 infection in people living with HIV. And if you take a look to the individual studies, one very important is the one of Bull and collaborators from South Africa. And in this study, despite the median CD4 cell count was not reported, we know that the overall population of people living with HIV had a low CD4 cell count. And the other important study here among the five included is the one of Tesoriero. As you can see, 35% and close to 34% of the weight for this relative risk. In this study, hospitalization risk increased with disease progression to HIV stage 2 or 3 compared to the stage 1. So probably this slightly higher attack rate is maybe related to the clinical condition, because the most important study, as I was explaining before, had an overall population of people living with HIV with low CD4 cell count. So maybe this higher attack rate is not the situation for the overall population of people living with HIV. And then moving to the second question. So some studies suggested a protective role of some antiretrovirals. Indeed, at the beginning, we were using antiretrovirals also for the treatment of SARS coronavirus 2 infection, and particularly for TDF, but not for TAF, which is difficult to understand, suggested that maybe in some studies, there may be some protective effect of TDF against SARS coronavirus 2 infection. One of these studies was a very big study from Spain, also the second one from the HIV Research Network, and the third one was the study of Bull and collaborators from South Africa, I have already mentioned. But however, these three studies have selection bias is very important, because it is unlikely that TDF is prescribed to older people living with HIV or those with known comorbidities such as cardiovascular disease, diabetes or kidney disease, all identified as independent risk factors for poor COVID-19 outcomes. And so many of these situations is really difficult to completely correct in these studies. Moreover, We have very recently published or presented studies, one from Spain, the other one from France, in uninfected people, because those are PrEP studies, so people who is not infected with HIV but is also receiving TDF. And in these studies, there were no evidence of any protection against SARS-CoV-2 provided by TDF. So I think that the question is still open, but we have clinical trials ongoing that probably will bring light to this question. But personally, I think that it's difficult to conclude that we have any clear protective role of TDF. And then for the third question, so what is the performance of the vaccines we have currently for people living with HIV? This is a table from a paper we have currently under review in infectious disease and therapy, where you see the results from vaccines approved by WHO or by European medicament agencies. And as you can see, the inclusion of HIV participants was really low. Those are huge phase 3 studies with a lot of patients included, really low numbers for HIV participants, and even efficacy for people living with HIV was even not reported in some of them. So overall, we can say that there's a really poor inclusion of people living with HIV in phase 3 randomized clinical trials for SARS-CoV-2 vaccines. However, we have two small studies very recently published, one with the Oxford vaccine from UK. I think the number was 54 people living with HIV, and the other one even smaller with the Pfizer vaccine. I think there were 12 people living with HIV and 17 controls, but both suggested that in people with good CD4 cell count, immune responses against SARS-CoV-2 vaccines are quite similar to that of the general population. Very recently, the CDC, the American CDC, launched consideration for the use of additional mRNA COVID-19 vaccines after initial 2-dose primary series for immunocompromised people. That was particularly directed to transplant recipients, but it's also possible to extrapolate this recommendation for all the population of immunocompromised individuals, including people living with HIV with low CD4 cell count. So in my opinion, for this first part, first topic of the presentation regarding the risk of COVID-19 in people living with HIV, I think that there may be a higher attack rate in people living with HIV, according particularly to this recent meta-analysis. However, I think this is related to the baseline characteristic of the patients, because the most important study in this meta-analysis is the one from South Africa, and patients had an advanced HIV disease. So probably that cannot be extrapolated to the overall population of people living with HIV. Then regarding the question of the protection of some antiretrovirals, I think this is not proven. There may be a role for TDF, but very strong biases were present in most of the studies. We have not seen that in PrEP population. Unfortunately, we have randomized clinical trials ongoing to have the answer for this question. And finally, the vaccine's performance, which is really important with the numbers of vaccines we have already provided. I think in people with high CD4 cell count, we can be sure that the protection rates are quite good. And for those who are quite immunosuppressed, we may need additional doses, which is in fact what we do for other diseases such as hepatitis B or maybe pneumococcal disease. So let's move now to the second part of this presentation, the second topic, which is the risk of progression to severe disease in people living with HIV. And I think that for this topic, the two main questions would be, what are the progression rates to ICU admission, mechanical ventilation, and death in people living with HIV? And the second one, what are the factors related to poor outcome? Is HIV infection itself, or are there high comorbidity rates we have in people living with HIV in the initial series with SARS-CoV-2 infection, or is maybe a subset of the people living with HIV, those with low CD4 cell count or untreated HIV infection? Let's try to answer these questions. So this is a table from a review article published in Lancet HIV some months ago, where you can see the initial series of people living with HIV with SARS-CoV-2 published until the end of 2020. And as you can see, the intensive care unit admission, mechanical ventilation, and mortality rate were quite variable. For example, for the mortality rate in the study of Etienne et al. From France, it was only 2%. And this other one from the United States, from Ho et al., it was 26%. And why these differences? Well, as you can see, at the beginning, they were very different in the design, with some studies including only hospitalized patients, other including ambulatory care and hospitalized patients, some considering only confirmed cases, and other both probable and confirmed cases. And so it's difficult to draw a clear conclusion with this initial series. And in this second table, what you can see, and it's very clear, is that this initial series, most of the patients had a very good immunological status. As you can see in this column, the CD4 cell count was quite high, 600 for the majority of these studies, and also very important, a very high prevalence of comorbidities in most of the series. But it's very important to highlight that at this point, when this review was published, the two biggest studies performed so far with people living with HIV and SARS coronavirus 2 infection, the one of Tesoriero et al. From the New York State in US, and the other one from UK from Mascaran et al., were still unpublished. So let's get back to the meta-analysis I mentioned before. And here what you can see is the figure of the association of HIV and mortality risk from COVID-19. And as you can see, with these 4 studies included, the relative risk for the overall random effect was close to 1.78. But again, I think we have to analyze where this result come from and discuss a little bit every single study included in this analysis. Again, the study of Boer et al., we know that they have very low CD4 cell count. What is reported in the paper is that only 24% had higher than 200 CD4 cell count. Then the Tesoriero et al., we mentioned already that hospitalization risk increased with disease progression to HIV, and of course, those who were dying were the most severely ill patients, so those hospitalized and not those on ambulatory care. And then for the other 2 studies from UK, Gueretti et al. And Mascaran et al., in the case of Gueretti, they tried to adjust for many variables such as sex, ethnicity, age. And finally, they concluded that HIV was an independent risk factor at close to 3 for hazard ratio, but really important information such as the CD4 cell count of the population was not provided. So I think we cannot extrapolate. It's true that most of the people in UK are receiving antiretroviral therapy, but we don't know the median CD4 cells in this study. And then for the 4th one, the one from Mascaran et al., which is the biggest, again, they tried to correct for many factors, and finally, there was an effect of 2.9 as an independent risk factor for mortality for HIV infection. But again, as you can see, we are lacking really important information such as CD4 cell count that is not reported in this study. So in my opinion, and this is the conclusion we had in another review paper that is currently under review, I think maybe HIV itself may have a role in COVID-19 progression, but I really think that people living with HIV seem to have a higher risk for severe COVID-19 outcomes, mainly in 2 clinical contexts. One is the situation of an uncontrolled HIV infection and or an advanced immunodeficiency, or the second one, additional comorbidities, as we have seen in the initial series published in Europe and US, or possibly the combination of both. And finally, I would like to mention this huge study that was presented very recently in the IIS in July from WHO, from the WHO Global Clinical Platform. And again, in this study with more than 160,000 people included, and among them 15,000 people living with HIV, again, they found that HIV infection was a significant independent risk factor for both severe critical COVID-19 presentation at hospital admission and mortality. But again, there were classical factors related to a poor outcome, and limitations are quite high because we only have information of antiretroviral drugs for 40% of the patients, and we don't know the median CD4 cell count. But most importantly, 95% of the people included in this study were from South Africa, where we know probably the median CD4 cell count was not very high. So again, I do not think we can extrapolate these results from WHO to the overall population of people living with HIV. So let's try to have some conclusions and some take-home messages from these 2 topics. I think that the risk for COVID-19 seems to be similar to that of the general population, although in pool analysis, attack rates may be slightly higher, particularly in immunocompromised patients, and probably in this subgroup, yes, probably attack rates are higher. then I think that for the moment, we don't have any clear protective role of antiretrovirals because all studies with TDF have relevant biases, but we will see this in randomized clinical trials. We have not seen this in PrEP studies. Vaccinations seem to provide comparable rates of protection than in general population for people living with HIV with high CD4 cell count, but we may need additional doses for those with low CD4 cell count, as we do already for other diseases. And finally, I think that HIV itself may play a role in poorer outcomes, but progression to severe COVID-19 disease in people living with HIV is mostly related to two clinical scenarios. The presence of comorbidities clearly related to COVID-19 bad outcomes, or low CD4 cell count, or untreated HIV infection, or the combination of both situations. So I would like to thank you very much for your attention, and I would like to have your questions now and your comments. And that's my town, that's my university and my hospital, and those are our Twitter profiles if you want to follow. And thanks again to Virology Education for the invitation.